All right. Okay. Well, welcome, guys. Welcome to the first of, many part series going through a pretty comprehensive review of bone soft tissue pathology. Uh, this is kind of requested by our enterprising resident Ahmed here, but we're trying to work on this together to make sure that everybody really gets as much bone soft tissue pathology as they feel comfortable with. I know it can be very rare tumors, so we don't get the chance to see everything every day. So hopefully, this series will kind of introduce you at least to every aspect of the specialty. And we'll kind of we'll be able to answer questions. It should be relatively interactive, so I'll kind of show slides as well. So feel free to jump in and speak out if you have suggestions for what we're looking at. The general way that this is going to go is I'll have kind of a lecture for every single subtopic that I have in bone and soft tissue. So we'll you know we'll eventually get through it all. All right, so today we're talking about adipocytic tumors, part of the soft tissue series. So let's get started. Perfect. Okay, so I like to start off with a little bit of an kind of a generalized approach to bone and soft tissue that will help you kind of really hone in on how to start thinking about these tumors before we even like get into the meat of the situation. So generally, when we approach BST tumors, we're thinking about things in a line differentiation approach. Um, or in the sort of morphological archetype approach. So whether we think something is adipocytic, that will help us kind of approach this kind of series of tumors. I like to focus on developing certain criteria. So what's necessary for the diagnosis? I really want you guys to think about, what's necessary, what's sufficient, what are extra features that, may or may not necessarily be there, right? And I think this is something I want to always stress to you guys is that, pathology, it's really full of bad examples. It's just a lot of stuff that does not look like the textbook. So be prepared to kind of have specific necessary criteria down so that if you don't happen to have some of the extraneous stuff, you can still make that diagnosis. Okay, so this is the adipocytic line of differentiation. This is every tumor in the WHO book. It's not every single adipocytic tumor out there. Of course, there are other things that may be named, different tumors, but this is kind of going to be what we're going to go over generally, as well as a few other things. All right, so the approach to adipocytic tumors in general, we want to start from kind of approaching these from a morphology standpoint, right? So we'll always think about the histology first, right? Adipocytic tumors, they form the spectrum, kind of like some of the most benign tumors to the rarest tumors in the whole body. Most of them are benign, the vast majority, and the benign ones have pretty distinct morphological features with pretty set criteria, I would say. IHC and molecular testing is pretty rarely needed in the benign setting. There are a few sort of rare malignancies, and they have certain predilections for age groups and locations, which we'll talk about, of course. And there are some categories that are relatively well defined, but again, morphology is the key to making this diagnosis. Yep. All right, so the way we judge what an adipocytic line differentiation is by looking for adipocytes, right? So it needs to have some presence of adipocytes, and there's a variable amount of non-adipocytic tissues present in these tumors as well. And there can be a lot of overlap with non-adipocytic tumors. Sometimes you can get, for example, lipomatous metaplasia within a fibroblastic tumor. And then some tumors really don't have a whole lot of fat at all, though they may be adipocytic, right? So they run the sort of the spectrum from very low amount of fat to a very high amount of fat, right? So on one end of the spectrum where it's all pretty much all fat, things like lipomas, that kind of thing, versus dedifferentiated liposarcoma, which basically does not have fat, right? So the amount of fat does not necessarily preclude making a diagnosis of an adipocytic tumor. Okay. All right, so let's jump in here. I'm going to start with lipomas, and then we'll start to kind of like take a look at some slides as well. I don't have a digital slide of lipoma because I don't think I know any single person who would want to spend time scanning lipomas. But we will have some. I'll have plenty of slides for you guys to look at as well. So, lipomas are the most common mesenchymal tumor in the body. And they're benign tumors, but they have limited growth potential overall. And really, the only reason we actually look at these is because there's a risk for atypical lipomatous tumor, which has a predilection to become a sarcoma, right? But lipomas are completely benign. So we want to be able to distinguish the two of those. So, what do you need to make this diagnosis? So, these are the most, I'd like to set this off to the side here, the histologic criteria. This is kind of what I need generally to make these diagnoses, and what I would recommend you guys kind of follow and use to be able to make a diagnosis of this. So, lipomas, they generally need to be predominantly mature adipose tissue, right? So they will be the adipocytes will be kind of the same size and shape generally. It'll be mature adipose. There's minimal variation, like I said, and then there's no large hyperchromatic cells, right? And we'll talk about what that means. There's a lot of additional features. These are not necessary. They're not like important. The presence of them does not tell you anything different, right? So you can have areas of fat necrosis. You have a lot of myxoid change in these things. You can have a bone and cartilaginous metaplasia, so it's not, they're not always going to be only adipose tissue, but the lesional cells will be mostly adipose, right? All right. So of course, it just looks like this. Mature adipose tissue. Pretty straightforward, right? So round adipocytic neoplasm. All right. And then here's another example, just kind of showing you a kind of one that has a little bit more fibrosis in between. And then here's one where you see kind of inter invading into skeletal muscle. Lipomas can do that. They can be kind of infiltrative, right? Okay. All right. So when we talk about when we sit down, and you'll sit down with me and sign out, we will always talk about a method for screening lipomas. Like I said, that distinction between lipoma and atypical lipomatous tumor is the most crucial kind of bread and butter diagnosis that we deal with on BST. So we have a specific method that we screen these at. So basically, you have to follow these three rules, right? So one, make sure the tumor is well sampled. So that means 1 per centimeter. If you give me, 8 centimeters in a 9 centimeter tumor, I'm sending you back. Sorry. In two, you look through the entire lesion, you look through the entire neoplasm at 4x, right? We don't want to go too high up because things start to look big at 10 and 20 and 40x, right? So use 4x as a good marker. When you start seeing large cells at 4x that are hyperchromatic and atypical looking, and that may be in the fat or in the fibrous tissue around the vessels, those are your diagnostic cells for a typical lipomatous tumor, right? We'll go into what a ALT is. Of course, I think you guys may be familiar, but we'll kind of go through the whole idea. And then lastly, I follow a rule that I call the rule of dry for my mentor. Basically, you should have this mantra that if there's going to be a large hyperchromatic cell in this entire thing, it's going to be in the second to last slide that you're going to look at, unfortunately, regardless of what order you look at it in. That's just kind of the nature of pathology. All right. Of course, if you don't see any atypical cells, you don't need further testing. So that's why we screen like this, is to not necessitate a whole bunch of MDM2 testing, right? So, but if the tumor's not well sampled, or if there's some indeterminate cells, these are situations where I would consider further testing, right? Of course, all it takes is one definitive atypical cell to call it ALT. Okay, so we'll get into that later on. But let's go ahead to our first slide. So this is going to be we're going to give this a shot here and hope that it works. And I'm just going to log into my thing here real quick, and I'll move this over. Okay, so we're going to look at our first. Go. All right. So we'll look at our first sample here. Okay. So let's see. So anybody want to describe what we're seeing here?
Sure. There's mature adipose tissue filling the entire field, and there's some few intermingling vessels and fibrous septi.
Perfect. All right. So exactly. So we're looking at mature adipose tissue. I already told you that I don't have any scanned lipomas. So you might wonder like why am I showing you this case here? Well, there's something else that's happening in this lesion, and I'll show you that. And since Mom and you started, why don't we continue on with you here?
Okay. There. Oh yeah. There's some spindle cells in these septi, some of which are fairly large and hyperchromatic, at least at this power, and there's intermingling vasculature.
Okay, so we have some spindle cells, we have some intervening vasculature. Let's take a closer look at these guys. What do you think? Any possible differentials? So you're spot on. There's vascularity here to it.
Yeah.
What
On
else?
my differential is angiolipoma, but I would also look for thrombosed vessels like
hmm
microthrombi.
Perfect. Okay, so thinking also potentially about angiolipoma. Okay, so what are your criteria to diagnose an angiolipoma?
There should be uh, sort of it should be a lipoma,
Mhm. So
and there
mature
should be
adipose tissue. Yep.
yeah mature adipose tissue,
Mhm.
and there should be sort of a vasculature that is anastomosing vessels, almost forming a confluence, and we should have fibrin microthrombi.
Right. So like a confluence of kind of tightly bound kind of capillary vessels, right? And fiber microthrombi are nice to have as well. So, all right, perfect. So exactly, that's kind of what we're looking at here. And I'm gonna try to keep things moving, of course, because we don't want to spend three years talking on a in this hour lecture, and we got a lot to do. But I'll point out that you had the exact kind of thought process here that I want. Let me show you another one of these. Here's another example. And in this one, you can see there's quite a lot more capillary vasculature. And this is pretty typical, right? So you expect to see variable amounts of mature adipose tissue with small capillary sized vessels. Now, let me see if I can find a quick good example of a fibrin microthrombus for you right here. Let's see. Let's see here. They should be over here somewhere. Here we go. Here we are. And this
Oh.
one has plenty of them. So you can see this kind of purplish fibrin that you'll see. That's very typical in these vessels. You'll see at least a couple, right? All right. So these are good examples, exactly what Mohammed's saying. This is great examples of angiolipoma. All right, let's move on. There we go. So they're angiolipomas. So exactly what he said, the histologic criteria are thus, right? So mature adipose tissue in variable proportion, and you'll get clusters of capillary-sized vessels and fibrin microthrombi. Okay, that's what you need. Now there can be more cellular variants, what we call cellular angiolipoma, that have much less adipose tissue and are almost entirely capillary-sized vessels. That can be a little difficult to make that distinction, but it helps to see some adipocytes near the periphery of it, and to know that there may be other lesions, right? Because angiolipomas are very typically multifocal. So there's multiple of them that happen generally along the extremities, upper extremities, lower extremities in the trunk. And they can be painful. So you can always check your clinical and see that might help you. Okay. All right. Moving on.
For these angiolipoma, do you need fibrin microthrombi or can you make the diagnosis without seeing them?
Generally, they're nice to have. I like to see them, but if you have that specific capillary architecture, then you can be pretty certain. The unfortunate thing is that when these tumors get quite large, the number of capillaries they really kind of thin out, right, and they get pushed towards the periphery, so you don't really get to see a whole lot of them, right? But if you still they'll still have that nice like clustered architecture, and that can really help you. All right. Lovely. Okay. Moving on to the next slide. Let's see if we can get this going. All right. Here we go. Okay. Next up, All right, who wants to take this one? All right, I'll settle in on a spot for you guys.
Do you think you can maximize the screen?
Let me see. Here we go.
Oh yeah.
Yeah, that's nice.
Mhm.
Yeah, I can take this one. It seems like we do have an adipocytic lesion.
Okay.
What's striking for me from low power is that I do see some cells that are small. I see some cells that are large. So I feel like there's some sort of variation
Okay.
in the sizes of the cells. Some of these cells from this power kind of look like they have this foaminess to the cytoplasm.
Mhm.
I agree.
Yeah. So when I see, like these, when I see this foaminess, I think, is this lipoblast,
Okay.
like a multivacuolated lipoblast, or
Could be.
something else that I can think of is like a hibernoma,
Hmm.
which is brown
How
adipose
do you
tissue.
make a diagnosis of a hibernoma?
I think for hibernoma, I want to see an adipocytic lesion with adipocytic cells that are multivacuolated.
Okay. So multivaculation, I think that's an interesting way to put it. It's true, it's multivaculated, but it's hard to distinguish that from like a multivaculated lipoblast when you put it that way.
Oh,
That's true, right? But if you think about it in the context of kind of more um, almost like bubbly
oh,
or
foamy.
or microvesicular, almost like think of like microsteatosis, for example.
Yeah.
Similar idea, right? So think of these as kind of like these little small little rounded punctate uh, um, spaces within the cells, right?
Mm,
Okay, what are these cells?
mm,
What are we what exactly what kind of tissue is this, right? Because we have mature adipose tissue here, I agree. But
yeah.
what are the foamy
Are
cells?
these lipoblasts?
They're not
Are they,
lipoblast.
is it just brown fat?
It's brown fat, right?
Mm,
Exactly, right. It's what some people will call hibernoma cells, but they are essentially they're brown fat or fetal type adipose tissue, right? So those are the kind of the names that you might call it. I think that's my only one, right? Yeah. Perfect. Okay, let me move this back over. Great job, guys. Take a look.
Wait. How do you tell the difference between the hibernoma brown fat cells versus the lipoblast?
Okay, good question. So let's bring this back. Yep. Okay, so when you take a look at these cells, right, you can see that generally, for one, generally you'll see a nice kind of centralized round nucleus. Most of the time, these cells are not really going to be indenting too much. They won't be hyperchromatic and like indented by the the vacuoles, right? You'll also generally see, let's see, they'll generally be more round. Like I'm just trying to point out some here for you. The nuclei are generally going to be more rounded.
Okay.
And they may have little nucleoli as well, right? But the other thing is that most of the time you're in a mature adipocytic tumor, you're really not going to be looking for lipoblasts because you're not expecting to see a whole lot of them, right? And the other thing is the size, right? So they're quite large here.
Yeah.
Okay, so those are the kind of things you want to keep in mind. All right, let's move this back over. Okay, so yeah, you're right. It's a hibernoma. Hibernomas, kind of interestingly enough, are pretty rare in children, even though they're full of fetal type adipose tissue. They typically happen in like 20s to 40s, right? But they are benign. They're basically same prognosis as a lipoma. Some things that you should kind of understand is that sometimes your radiologist will be a little bit, there'll be a little bit of a different appearance to it than just the regular lipoma, as you might expect, because it doesn't look like mature adipose tissue. So on MRI, you might see like a lower signal intensity than sub-Q fat. And when they do a fat suppression technique, you may only get like partial signal loss, not like complete signal loss, which is what a fat suppression technique will do. And then grossly, you can actually see that it's a little slightly more brownish, right? Almost like becoming a little bit more oncocytic, like an oncocytic type neoplasm, slightly more brownish, not like mahogany brown, but
Right.
get there. Okay, so my histologic criteria that I go by is variable amounts of mature adipocytic tissue and fetal type brown fat, right? And then, of course, you're not supposed to see any hyperchromatic atypical cells. Generally, it's pretty rare for an atypical lipomatous tumor to have like hibernoma features. But I have seen it once. It's just most of the time you're not going to run into something like that. All right. Any questions about that one? Okay. All right. Let's get on to slide 3. Okay. Yep. All right. So let's take a look at this one. Who wants to take this one? I guess we can start at low power first. Very low power.
Yeah, I can go ahead and take this one too.
Yeah.
It looks like we're looking at an adipocytic lesion from low power. What's
Okay.
striking me from low power as well is the presence of these fibrous septae. And I can't make out if there's some vessels here. Is it like an angiolipoma or is it something else?
Okay. So there's definitely this kind of intervening component, right? But
Mhm.
mature adipose tissue otherwise.
Yes.
All
So
right.
for this intervening component, it looks like fascicular, like fascicles of
Yeah,
spindle
yeah.
cells.
Fascicles. Yeah, nice. Fascicles,
Yeah.
spindle cells. You want to describe the cells?
Yeah, so it looks like we do have these spindle type cells, kind of wavy-ish. Looking at the cytoplasm for these cells, it looks more like a grayish cytoplasm, more like a fibroblast or a myofibroblast rather than smooth muscle or neural. It looks to me more
Oh,
like a fibroblast, myofibroblast.
I
Sure.
think it looks more eosinophilic.
A little bit more. There's like a pale kind of eosinophilic,
Yeah, yeah.
Mhm.
but maybe not like muscle, right? What about
Yeah,
this stuff? What are these?
Ropey
Collagen.
collagen, maybe.
Ropey collagen. That's right, exactly. Yeah, there's this kind of ropey collagen background. A few bundles here and there in a spindle thing. What do you guys think this is?
yeah, I think it's probably,
Spindle cell lipoma.
yeah,
Yeah, there you
or
go.
a mammary type myofibroblastoma.
Okay, well now you're yeah, that's true there. Now, Ahmed brings up a good point. This exists on a spectrum along with a few other tumors that we can talk about in a little bit later on. But that's a good example of a spindle cell lipoma. I think I have another example over here for you. This one showing that nice big bundles of collagen.
Yeah, yeah, those are big.
Yeah, this is more ropey. This is more convincing. Last
More
one I
convinced.
didn't
Yeah, it's
buy.
a
What, you were
rope.
not convinced? Oh my gosh. Getting denied. I know. But yeah, so again, bigger bundles of collagen here. The other one was a little bit more cellular. Okay. So in some of these tumors, you may also see some scattered giant cells as well. And the reason for that is that spindle cell lipomas um, are also kind of the same thing as what's called pleomorphic lipoma. So the two kind of exist in the same spectrum. You just may see more scattered giant cells in pleomorphic lipoma. All right, great job. Here we go. All right, so spindle cell lipomas, they're benign, right? Um, but they have a very low risk for any local recurrence generally. They're even though we think that they're called lipomas, they're actually distinct tumors. They're not a lipoma variant necessarily. They have like molecularly and morphologically distinct. Of course, they can usually on the upper back and neck, but they happen everywhere. So I would say about 80% of them are on the back, but the rest happen literally anywhere. The one caveat is I would be hesitant to jump into a diagnosis of it in the retroperitoneum. These things are vanishingly rare. You should really expect that there's a different tumor in the retroperitoneum, which we'll talk about. All right, so here's your histologic criteria. So this is what I would kind of focus on. You're going to have variable amounts of bland spindle cells, maybe with some multinucleated giant cells, right, if it's more pleomorphic, in fascicles with admixed mature adipose tissue, right? There'll be thick, ropey collagen bundles and no significant cytologic atypia, right? So you're not having the hyperchromatic atypical cells of an ALT. There's some additional features. These often have a lot of myxoid change as well. Don't get fooled by that. And there are some weird variants like the fat poor variant, what we sometimes call the California spindle cell lipoma. But that basically doesn't have any fat. And then you've got the pseudoangiomatous variant, which almost looks sort of almost like cotyledonoid, or like they look like villi almost, right? Because there's like there's this sort of pseudoangiomatous prolifer architecture to it. That's pretty rare, but it is kind of a fun thing to see. And then okay, for your boards, obviously for everything, there are some IHC and molecular that may be relevant. These things, they don't generally need a whole lot of IHC, but the spindle cells will usually be 34 positive and they're RB1 lost. So we have a stain for RB1, you can do that. It will be lost in like more than 90% of these. And cytogenetically, that maps to a loss of 13q14. So we don't really do the cytogenetics for that anymore. But again, very morphologic diagnosis for these. But if you need to, an RB1 is useful. Cool. All right. Moving on. There's another slide here. Let's take a look. Okay. Let me put this up here. Let's start with this one. Here we go. All right. So, okay, where are we first of all?
Yeah, it seems like looking at this slide, I see a foveolar epithelium on the surface, and then I
Yeah.
see some parietal angief cells. So I think we're in the stomach here.
Okay. Sounds good. I think we're somewhere in the GI tract, you know. I won't bore you with the details of trying to figure out where along the
Yeah, it looks like we do have this adipocytic lesion. What's striking from low power is that the location, first of all, it seems like this location is a submucosal lesion,
Yeah, it seems to be
possibly.
submucosal. Yeah. There you go.
Yeah,
But
it looks like hmm?
what is all this stuff here? What are these?
It looks like we have a lot of myxoid change.
I agree, there's myxoid change. That's true. That's true. What about this stuff? The big pink stuff here.
It looks like fiber septae.
Yeah,
Yeah, it
Yeah,
looks like a part of the lesion. It doesn't look like this is like
part of the
normal.
lesion.
Yeah,
right. Weird, right? It's kind of
yeah,
like
It's
big
weird.
fibrous septae. Okay,
yeah.
cool. All right. What else do you guys think about this?
So now we're going high power. I see like three components. I see an adipocytic component. I see this component of cells that are kind of running in fascicles. And then I do see these foci, which I'm trying to figure out whether this is sort of maybe myxoid chain.
Yeah,
That's a
yeah, immature.
possibility.
Yeah.
Then what if this is immature mesenchymal tissue? That's another
Uh,
possibility.
Okay. So myxoid change is looking a little weird and primitive for some reason.
definitely.
Yeah.
That's true. And I agree. There's fibrous banding running throughout, which is nice. There is also, given that this is in the bowel wall, there's something interesting that there is a sort of weird, what is all this here, for example?
With muscle.
Yeah, smooth muscle. So we are getting some banding of the smooth muscle from the wall that's being disrupted, that's extending into this tumor. So that's kind of interesting. But there is a lot of fibrosis as well. Okay.
Yeah. So I think the challenging part for me for this is there like a fibrous tissue as part of the lesion? And in that case, I think the diagnosis would be something like fibrous hamartoma of infancy. But
Okay.
then another consideration is that this kind of look chondroid. So I'm thinking like a chondroid lipoma as well.
All right. Going for the weird stuff, going for tumor, right?
Does fibrous hamartoma of infancy occur in the stomach or GI tract though?
It's be very rare, but I'm not going to say no.
Yeah,
see,
never say
sure.
never. Yeah.
But what do you
Sure.
think a
If it's a
diagnosis?
child, I would consider lipoblastoma as well.
All right, great,
What
great.
an intramuscular lipoma.
Yeah, or intramuscular. Well, intramuscular we give to like skeletal muscle, kind of, but not like the smooth muscle of the wall. We wouldn't really call that. But it could be just a regular lipoma of the bowel wall. That's true. Very true. Okay, so something that I think Alcino's kind of pointed out here, these smaller cells here. I think he's noted the presence of that fibrous tissue and some of the myxoid change, and these little guys, which are lipoblasts. So he wants to give us a lipoblastoma diagnosis, and I think that's a fantastic idea. Ahmed, you said fibrous hamartoma of infancy. What do you need to make that diagnosis?
You need three components. You
Uh-huh.
see a mature adipocytic component.
Mhm.
You want to see fascicles of spindle cells.
Right, which is more like fiber. It's like a fibrous kind of
Oh.
background. There's fibrous backgrounds. It's fibrous hamartoma, right?
Mm.
Mature adipose tissue, and then the third component, that primitive component, is generally more of these like world kind of neural components. But rather than just kind of like some primitive looking kind of stellate cells, they are pretty tightly wound kind of neural components. So they're primitive neural component.
Okay,
Right?
okay.
Cool. All right. Anyways, but we do have a lot of lipoblast in here as you start to look, right? And intervening fibrous tissue. Perfect. All right, here's another example I'll show you real quick. A little bit more traditional. Here again, as you can see, a low power again, pretty striking kind of fibrous banding and fibrous tissue
Yeah.
that runs through. And then a very myxoid background is very typical and lots of small little lipoblasts, right? So we've got a good example here of a lipoblastoma. So Alcino was right on.
Wait.
Mark,
This one kind of looks like Myxoid
this one looks
liposarcoma.
so different from the other one.
Oh, it looks
Even
like.
blue. Where's the blue? There's not even that blue look to it.
Oh, come on now. It looks like myxoid, right? Looks like myxoid. Now you're wondering, could this be myxoid
Yeah.
liposarcoma? Oh, okay.
No.
I mean, it has univaculated lipoblast, and
It
then the
does have
vascular.
a lot of lipoblast. It does have a lot of lipoblast. That's true. That's
Yeah.
true.
It has
Yeah,
this
but,
characteristic vasculature.
you
Crow's
wonder
feet.
Mhm. Yeah, that's true. That's true. It's scary, right? Okay, so this is, again, I'm showing this specifically because this is one of the biggest differentials with lipoblastoma, myxoid liposarcoma. This actually does not have the fusion, and morphologically, it has a better look for lipoblastoma overall. And it's in a much younger patient. I think it's like a 10-year-old. So this is very scary though. You might consider, like, you really want to think about myxoid liposarcoma a lot when you have kind of a bit more of an adult patient who has kind of morphology like this, and consider if it looks like a lipoblastoma, you may consider doing fusion testing as well. All right, so I know you. I'm glad you stopped me because I was just gonna walk right by. So this is a lipoblastoma. That's true. These are benign. They do have some local recurrence potential. It's not unusual. Most are in patients younger than 3 years old. I have seen a couple in the adult population. It's really not like unheard of.
We have
Um,
one.
oh yeah, we did. I'm pretty sure. But yeah, most of them are in kids. And the thing is, they may actually stick around over time, and some people think that they may mature into like regular lipomas. That if they stay for a long time, you might actually see that. Um, and I think it's really important to consider and remember that liposarcomas in general in kids, like younger than like 5 years old, 10 years old, is extremely rare. So you really want to be careful, again, making that diagnosis. You really want to prove it, right? Rather than just like, hey, morphologically, this looks perfect. I'm going to go for it. Right. All right, so the histologic criteria. You need a lobulated architecture, generally, which we saw in both of these. Large fibrovascular septa is pretty typical, and then adipocytes with variable maturation, including generally many lipoblasts. And these can have a lot of myxoid change, right? That's the big kicker. And they can have some areas that are sometimes more primitive or round to stellate. So you got to be a little careful. Sometimes they get quite cellular. All right, and then for IHC, they have some weird IHC, as you might expect, for everything in the children's land. It's all kind of weirdly staining sometimes. They will stain with 34 and S100, but sometimes they have like Desmond and P16 positivity, weirdly enough. Don't ask why. I don't know. But the molecular is nice that it's different than myxoid liposarcoma, right? So these have PLAG1 rearrangements, and you can actually do a PLAG1 stain and diagnose it, right? Cool. All right, any
Do
questions
you
about
see this plaque one? Mark Montgomery, you see this plaque one here?
Yeah, Plague one, I got it.
Okay, awesome.
Plag 1, guys? All right. There's only one other situation where Plag 1 is diagnostically relevant. What's that?
Pleomorphic adenoma.
Yeah, exactly. Pleomorphic adenomas, right? So we have the
And
same
mixed
for
tumor,
yeah, mixed tumor, right?
cutaneous
Okay,
mixed tumor.
same
Yeah.
thing, same thing. Mixed tumor, benign mixed tumor, soft tissue. And we have the stain more for pleomorphic adenoma, but it doubles as a nice stain for lipoblastoma if we need it. All right, so the last one I'm going to show here is chondroid lipoma. Unfortunately, I'm sorry, guys, I don't have a chondroid lipoma slide. I have looked for one for like the past 10 years. I do not have a scan of it. I'm sorry, but it's a pretty distinct tumor, and a picture kind of shows you the general idea pretty well. So it's a pretty unique adipocytic tumor. Ultimately, it's benign, even though it kind of looks so weird. Basically, it's the same prognosis as a lipoma. This is another tumor that can cause some confusion with myxoid liposarc, right? And then there's one thing I want to note. Don't confuse chondroid lipoma with a chondrolipoma, which we sort of colloquially call things sometimes when you have a lipoma with like cartilaginous metaplasia. Don't be like the public library on Path Presenter that has a chondrolipoma that's called chondroid lipoma. I'm getting my hopes up that I can actually find one of these. It's a digital slide. Unfortunately, no. That was a chondrolipoma. So chondroid lipoma is very specific neoplasm. It's not the same thing, right? So here's the histologic criteria. You have a mixture of mature adipocytes and lipoblasts, right? So they're generally a bunch of like lipoblast-like cells, and they almost look, either cells look kind of very like lipoblasts or like they're sitting in lacunar spaces. So they almost kind of have a kind of pseudo-cartilaginous appearance, right? And then you'll have an admixed chondroid to myxohyaline background, right? There is a gene fusion. You're never going to be asked this ever, and you're basically never going to do this ever. And I don't think even our lab picks up these genes, so I would not worry about it. But it's there for your personal information. And here's what a chondroid lipoma looks like, right? It doesn't just look like cartilage in a lipoma, right? You can tell cartilaginous metaplasia you would just see like lobules or nodules of just regular hyaline cartilage. This, on the other hand, has this nice kind of myxohyaline to chondroid stroma, and then a bunch of mature adipocytes, and then kind of like chondroid cartilaginous cells to lipoblastic type cells, admixed, right? So it's a very unique tumor, kind of an interesting look. You don't get to see it very often, though. Okay, any questions about chondroid lipoma?
Looks scary.
It is, right? It's a little
Looks scary. What's the prognosis?
benign, just a lipoma.
Okay.
I know it's one of those things that we spend hours kind of discussing, and it is completely inconsequential.
Years. I've looked for 10 years.
That's BST. All right. Okay, moving on. Digital slide number 5. I don't even know if I numbered these all correctly, but whatever. Okay, let's start with this one. Okay, who wants to take a look at this? So, what do you guys think? Or you can all shout it out together. It's fine.
Definitely adipocytic lesion.
Agree.
Okay. We're looking at a lot of mature adipocytes.
And very
Okay.
interesting fiber septae.
Okay.
Kind of thick.
Yeah.
Okay. All
Yeah.
right.
The screen at 4x.
Screening at 4. Somebody's screening at 4x. Somebody is. Oh, has somebody stopped over here? Maybe.
Yes. Looks like we have some scattered atypical hyperchromatic cells.
Yeah, exactly. Let me have this load up a little bit because it's let me load up this spot over here. That should help you. About that guy.
Ooh,
Oh
yeah.
Yeah, I like that guy.
Yeah, there you
You
go.
like it.
Large hyperchromatic atypical scales kind of scattered about, right? In the fiber septae, pretty typical, but in the fat, you might also see them. Here's another one right there, right?
It's big.
This is a very typical appearance. So what do you guys think this is?
The diagnosis is location dependent. If it's
Right.
either atypical lipomatous tumor or well-differentiated liposarcoma.
Okay, so let's say this is in the arm. What are you going to call it?
Atypical lipomatous tumor, ALT.
Okay, perfect. All right, excellent. So we will so what's the difference between that and well-diff liposarcoma?
I think if it's hard to resect, like if it's in the retroperitoneum or a location like that, then you call it a well-differentiated liposarcoma. But if it's easily accessible, you can take it easily, like in the extremities, you just call it atypical lipomatous tumor.
Right, exactly. And we'll talk about why in a second. We'll kind of re-synthesize all that in a moment. But yeah, so it's location dependent. The tumor is the exact same. It is the same tumor. It's just we're trying to be nice about it in some areas and we're trying to be mean about it in other areas. But generally, when you're in a bad location like the retroperitoneum or the thoracic cavity, you'll call it well-differentiated liposarcoma. Okay. All right. So that's a good example of one. Let me see. Do I have another one? I do have another one. All right. Where are we?
Kidney.
Kidneys, right? Okay. So what are you going to call this one? What about over here? See this?
Yeah, this one I'm going to call a well-differentiated liposarcoma.
Exactly. So it's
Sarcoma.
highlighting that, right? So this is again a mature adipocytic, mostly mature adipocytes, right? But then in these sclerotic bands, you're seeing a large amounts of these kind of like scattered hyperchromatic atypical cells. Now you just see them out and about, scattered about, not really like forming a large tumor mass and like a whole bunch of pleomorphic cells all together. Usually you'll just see them like this. Okay. All right. Let me see. Anything else to talk about with this one. Now, basically, this is just showing you a good an example of one in the retroperineum. Very typical location. Okay, here's another one. I'm just going to be showing a couple more of these to like give you some some more examples of what they might look like. The very much looks like a lipoma, but there are, let's see if I can find a few of these things. This thing will load. All right. Starting to get a little bit, maybe that guy there.
Yeah.
Yeah, starting to, yeah.
Right, exactly. So as you start to go through here, you might spot it. But you can also see that it's pretty few and far between, right? Like I mentioned before, you don't need that many, right? You only need one technically, one hyperchromatic cell. So sometimes they just look like lipomas pretty much. Okay. Let me see if I have another one here. Yeah, I do have another one here. What's this?
Yeah.
Some would think it's an angiolipoma, but I think it's just fat necrosis or a previous biopsy site or something.
Yeah, so it's fat necrosis, exactly. So in this area can be scary. People can wonder about the atypia here. Could this be an ALT? Because there's some like bigger cells, but it's filled with giant cells and histiocytes, mixed inflammation and fibrosis, right? So this is more fat necrosis. And that can happen in a lipoma just fine. You know, it happens in the vast majority of lipomas, to be honest. So don't get fooled by that, right? That said, pretty sure this one also had some atypical cells, like right here and here,
Yeah.
that are more defining for ALT, right? So this was also a well-diff liposarcoma. Here's another one right there. And here they are. There, these guys are pretty defining. Cool. All right, let me see if there's any more here. Or are we all good? Oh, okay.
Ooh.
Different kind of one, right? What is this?
Yeah, so many atypical hyperchromatic cells.
Yeah, there's a lot of them, right? This is
Yeah.
still an ALT, and just kind of showing you the spectrum, right? I said ALTs before, they don't quite have, they do generally, we don't think about lipoblasts all that often, but sometimes they do have lipoblasts, right? And they can be quite cellular at times, you know, but as long as they meet the criteria, it can still be an ALT, right? And we'll talk about what the criteria is. All right.
Dr. Over there?
Yeah.
I have a question. If you see that many atypical cells, do you want to sample more to look for like a DDIF component, or this doesn't really factor into
Of
the
course.
equation?
So all of these, I would sample very heavily. I would sample 1 per cm. But of course, when you're sampling as on the grossing bench for any of these types of tumors, you're also looking for grossly heterogeneous areas. So look for kind of like more solid foci to sample. So you want to kind of spread out where you're sampling, right? So it's not all just one particular area. Yeah. So you'll be in one like this, and I believe this one did have dedifferentiation later. But in this particular area, it's not dedifferentiated yet. Okay. All right, let's go into the whole spiel here. Okay, so atypical lipomatous tumor, right? So it's a benign tumor, even though we call it well-diff liposarcoma, for example, it's actually benign, right? We name it this because it has a propensity for dedifferentiation, right? So the prognosis overall will depend on kind of whether it dedifferentiates, and it depends on the location, right? So the morphology, though, is the exact same, regardless of the naming terminology. And the reason for all this is because ALTs in the superficial extremities and the trunk, these things basically have a very low D-diff risk, less than 2% generally, and the 20-year mortality is pretty much zero, right? But for tumors that arise in the retroperitoneum or in deep locations, or like around the spermatic cord or in the mediastinum, the D-diff risk is much higher, like over 20%. And the mortality, 20-year mortality is like more than 80%. Most of this is an incurable disease, right? Most of these patients will die either from the tumor, or they'll die with the tumor, right? It's not going to be cured. Most of the time, that's from local effect, from local spread, right, and how it's infecting the nearby organs. But once it de-diffs, then it will be able to metastasize, and people die from widely metastatic disease generally. Okay? That's why we separate out the names. Okay, so your histologic criteria. Got to have scattered, large, hyperchromatic atypical cells. You might see them in the fat or in fibrous tissues around the vessels. That's what we're looking for, those cells that I just showed you. By definition, mitotic activity needs to be less than 5 mites per 10, right? So the reason for this is that now recent studies have kind of shown that prognostically, these things are not bad tumors if they have less than 5 mitoses. So things that don't necessarily look like a traditional ALT, that may be more cellular. If it doesn't have those 5 mites, it's more likely to behave similar to an ALT. Now, there's some discussion, there's continuing discussion about this, of course, because there's everybody wants to talk about this idea of dedifferentiation in liposarcs. But needless to say, for now, it seems to be that mitotic count is like a better indicator of like the behavior of this thing. So if you have 5 and above mitotic figures, then you're in the realm of DDIF, right? And we'll talk about that later. Adipose tissue being in there is not necessary, right? You don't have to have it. There are some tumors that show very little adipose tissue or no adipose tissue. The reason for that is because ALT is one of these things that can have so many different morphologies. It's really variable morphologies. I've shown a few examples already that kind of look a little different, but there are many different subtypes, including the lipoma-like, which just looks mostly like a lipoma. There's sclerosing subtype, which has more sclerotic kind of fibrotic background. There's the inflammatory type, which is very inflamed generally. Cellular subtypes, which looks almost more like fibromatosis, very kind of like, or low-grade fibromyxoid sarcoma. It'll look very like a low-grade spindle cell tumor almost. And that's where people might call dedifferentiation, but the mitotic count differentiator really helps. Right. And then, okay, obviously, if you need help to make this diagnosis, MDM2 amplification, right? So do it by FISH. Don't even try IHC.
Don't even try.
No, don't. Now, I mean, I'm sure some lab out there wants to boast that they have the ability to do this by IHC, but the rest of us plebeians, we don't have the we can't, unfortunately.
Plebes.
I would not worry about it. Just do the FISH. Okay. All right. And here's some, I think I had an additional slide. Let me pull that open. Yeah, I had a few additional ones just to kind of show some variation. Here's another one here. So here's an example of a much more cellular one. So you can see almost like a spindle cell tumor. So we might be kind of consider like a sclerosing or cellular subtype here. But these areas pretty bland, and there are like scattered hyperchromatic cells as you go through, but there's less than 5 mitoses here, right? And it just doesn't feel like this is going to be a sarcoma, right? This side, on the other hand, kind of annoying, right?
Yeah, that was so ugly.
Much different.
Well, ugly, sure. I don't know. It doesn't look that ugly. It looks, don't be so mean.
Yeah, come
I just
on.
don't like the pattern, you know?
Very cellular, right? Very cellular. Now, this is, what's your suggestion here? That it's D-diff, right? The unfortunate thing is, or the fortunate thing for this patient, this does not reach 5 mitoses, right? This is actually the cellular subtype, right? So this is kind of showing you how cellular, how strange these things can get.
Truly.
This still, I would consider well-differentiated liposarcoma, right? Until it gets the 5 mitoses. I think there was like 1 or 2 mites in here, even though it's quite cellular.
But then how do you get to liposarcoma here? Like there is literally
Oh, how would you even call it a liposarcoma?
yeah.
That's tough with just this, right? And you can't even see like, because they all look fairly similar. You can't really see that. But consider it, obviously, I think this was a retroperitoneal mass, right? So if biopsy, you want to be a little careful not to, to have the high suspicion of that. But better yet, this thing had multiple areas and one that looked much better for a liposarc in here, for example, with these kind of larger hyperchromatic cells. And of course, it was MDM2 as well. Cool. Let me see if we have another example here. This is another example of a well-diff liposarc that is full of chronic inflammation. Right here, for example, full of this, right? But you still see occasional weird hyperchromatic cells as you look around. These guys here. This is what we call the inflammatory subtype, right? So it will sometimes almost look like a lymph node. It's so heavy with inflammation, but you'll still see the kind of scattered hyperchromatic cells in there. You just got to be a little careful. Here, as you move outside of the inflammation, start to see more of them. Right?
Yeah.
So be careful, especially in the retroperitoneum. Sometimes you'll get these that the radiologist will not at all think liposarc. They'll be like, kind of looks weirdly like lymphoid, maybe a lymphangioma or something like that. They're wondering about other stuff, or lymphoma, right? And after it gets to your desk after 3 weeks of being on the lymphoma team, you'll get it and eventually be like, maybe I should do MDM too, right? And you'll pick it up. Okay.
So for these inflammatory ones, it's usually chronic inflammation. We don't ever see them with I mean, I'm sure we can, but it's not usually.
You can see with newts and with
Okay.
well, but it's usually a lot of like lymphohistiocytic inflammation.
Sure.
Let me see. I think it's another example, right? Yeah, here we go. Just another example showing you kind of a little bit more kind of nodular inflammation, but again, probably a few large cells scattered about in here. Yeah, like maybe that guy right there and here. Okay. All right. Yeah, those are some of those examples. Weird cases. All right. Okay, moving on to the next one. All right, what is this one? Okay, let's start over here with this one. Okay, so what are we looking at here?
I don't like what I'm seeing. So it seems like we do have an adipocytic lesion.
Mhm.
I see some scattered kind of atypical hyperchromatic cells. I just saw one.
Yeah, they're not that big though.
Right. They're not huge, but as we go around, we might see a few more. Maybe that
Yeah,
guy, maybe this guy,
yeah. I see a
Okay.
couple.
and then over here.
Yep. I think that's enough for me for
Okay. Well, diff.
LT versus well-diff, depending
Okay.
on location.
What is
Oof.
going on here?
Yeah, I don't like
This
what I'm
focus.
seeing here.
Yeah.
First of all, it looks first of all, there's a sharp demarcation between both
Mhm.
parts. Like
Sure.
the part on the right looks completely different from the part on the left. Secondly, I see proliferation of a lot of spindle cells that are fascicular. I see a lot of atypical hyperchromatic cells scattered here and there.
Yeah.
Kind of storiform-ish in some areas.
Kind of right, exactly. There's a bit of a architecture to it for sure. We could go on and describe the various architectural features, but the one big thing I want to point out is that there's mitotic activity. One right there. I saw another one around here somewhere. And if you count it up, I would assume that there's another one right there,
Oh yeah.
and one right there, and here, and here.
Oh yeah, yeah.
Yeah, so we've counted 5 in like the 1 or 2 sections that we looked at. Okay, so we have enough, right? So want to call it
D-diff liposarcoma.
D-diff lipo, exactly. So this is an area of D-diff in arising from a well-diff, right? We'll talk about criteria in a second. Let me see if I can show you some more examples. Here's another one. It's a good example here.
Ooh,
Horrifying, right?
that one's bad.
Terrifying,
Yeah, with some
chilling.
atypical mitotic figures.
Right. Oh, yeah. And it's basically, has the morphology of a high-grade sarcoma, right?
Yeah.
High-grade pleomorphic sarcoma.
Look at that in the bottom corner.
Oh, yeah. It's right there. Yep. And then I think there's probably another one in here. Yeah. Similar features, right? Yep. High-grade pleomorphic
Oh,
sarcoma.
yeah.
Okay. So these are classic for D. diff liposarcoma. So how do we get to a diagnosis of D. diff liposarcoma? I've shown you kind of one way, which is the first slide.
Yeah, when it says sharp demarcation between two components, a well-differentiated component and a de-differentiated component.
Okay. And what do you mean by a de-differentiated component?
I mean a component that is high grade with a high grade pleomorphic sarcoma.
Right, exactly. It's generally most of the time will give you a pleomorphic sarcoma appearance. Now, de-differentiation doesn't necessarily only mean that it's going to be like a undifferentiated pleomorphic sarcoma. You can actually have any morphology when you de-diff, as long as it's implied that it's a higher grade, right? So you have to have the mitotic figures. The tumor is a higher grade. So generally, it's either intermediate to high grade in total, but it can have any sort of differentiation, right? You can see it with osteosarcomatous differentiation, rhabdomyosarcomatous differentiation, all that stuff, right? So not unusual, but most of the time it'll look like a high-grade pleomorphic undifferentiated sarcoma, right? Okay. What else? How can you make a differential? How can you make a diagnosis if you don't have a well-diff component?
Patient's history.
History, yeah, that helps. That helps. True.
Yeah, I think location is very important.
Location is very important. That's true. All right.
And then you can do MDM2.
And you can do MDM2. Okay, let's talk about that stuff. Yoop. All right, DDiff. Okay, so DDiff by design, we designed it specifically. By design, it's transformation of an ALT to a conventional sarcoma, right? By definition, it is an intermediate to a high-grade tumor, right? So none of this kind of low-grade dedifferentiation stuff, we don't really talk about that anymore. We're leaving that behind back in the 2000s. All right, so, and it's a malignancy, obviously. Prognosis in these cases depends on the grade, and not necessarily on the tumor histology. For example, if you have an osteosarcoma, it's not going to behave necessarily like an osteosarcoma. It'll behave like a D. diff lipo, right? Okay, so here's your histologic criteria. Either you have that combined ALT component with a sarcomatous component, right? Generally looking like a high-grade pleomorphic sarcoma, or you have the sarcomatous component alone with MDM2 amplification. Now, you have to be, there's a few caveats. One, it needs to be a relatively high level of amplification. Like it has to not, like most of the time, it'll be a high ratio and high copy number, more than like 10 to 15 copies of MDM2 most of the time, right? And you have to make sure you're not in like a better situation for another tumor. So what other tumors can have MDM2 amplification?
Intimal sarcoma.
Intimal sarcoma, that's true, right? Exactly. So if you're in the heart or the pulmonary arterial vasculature, and you get an MDM2, you're not calling that D. diff liposarc, right? Okay. What else?
Low-grade osteosarcoma.
Low-grade osteosarcomas, right? Exactly. So if you're within the bone, you really are going to be considering more sort of this low-grade osteosarc. If you have a low-grade osteosarcoma with transformation to a high-grade tumor, that's pretty typical as well. But those will also have MDM2 amplification, right? So that's another thing. And the last thing is any sarcoma can have non-specific MDM2 amplification. Generally, it's a low level, right? You'll have a little bit of amplification. So this really comes into play more when you have tumors that have a very particular appearance, like a myxofibrosarcoma, for example. A pretty significant number of them, about 10%, actually have an MDM2 amplification, but very like low grade generally. And the morphology will be a pretty classic myxofibrosarcoma. So if you've got like an old guy with a superficial kind of sub-Q tumor in the leg, and it looks like myxofibrosarcoma all through and through, don't be fooled by an MDM2. Okay. And then, like I said, sarcomatous component can have any morphology, and mitotic activity needs to be greater than or equal to 5 mites. All right. I think we have a few more to go. We're at 6 p.m. I think I can keep going. I think that might be easiest, and we'll just kind of keep moving along. But feel free if anybody needs to run out. Totally fine. And
I have a quick question.
Yeah.
So can the dedifferentiated component be myxofibrosarcoma?
Yes, it can. It can, right? So you can have a well-diff and then something that looks like a D-diff, right? Or something that looks like myxofibrosarcoma, that's a D-diff. That's totally fine. You can. Like, for example, if I saw a myxofibrosarcoma in the retroperitoneum, I'm heavily looking for areas of well-diff liposarcoma, right?
Okay.
You can get that. And in fact, I would generally search for that if you have a myxofibrosarcoma in the leg with an MDM2. I'm still kind of looking around, making sure there's no adjacent well-diff component, right? Okay. All right. Moving on to slide 7. Let's see. Here we go. Okay, let's take a look at this one. Oops. Let's take a look at this one over here. Okay, so there's only so many more tumors left, to be honest, right? What do you guys think about this one?
I think what's striking for this one is a lot of univaculated lipoblasts.
That's true. A lot of small univaculated lipoblast. That's true.
And I see some small vessels.
Small vessels, yeah, exactly.
Yeah.
And the background?
Is myxoid.
Yeah,
background.
it's myxoid. It's a little hyaline in this example, but it kind of myxoid stroma as well. Okay. We see,
Yeah.
point out some areas in the back here. Okay. All righty. What about this one over here?
This one here also similarly, we do have some kind of myxohyaline background. I do see some thin walled vessels, especially around the periphery. I'm on the lookout for some sort of like lipoblasts, but then suddenly I see this like a small round blue cell tumor here, and
Okay.
it has a typical vasculature for a myxoid liposarcoma. So I think this one is a high-grade myxoid liposarcoma.
Right. So exactly. You have these nice capillary vessels.
Oh yeah.
Yeah, it's a little harder to see the lipoblast, but if you look in, they're still scattered about in a few areas here. Okay. All right, excellent. So, example, this is myxoid liposarcoma. Okay, and I showed you an example of two variants of this thing, so-called low grade and high grade, right? So, low grade myxoid liposarcoma and high grade. What's your criteria to diagnose high grade myxoid liposarcoma?
I want to see a round cell component, meaning a round, small round blue cell tumor.
Yeah, exactly. So you need a small round blue cell tumor. Basically, the nuclei need to have a high nuclear density. So you'll have conventional areas of myxoid liposarcoma, and then an area that has basically high density. So like the nuclei are almost touching generally. So it's like small round blue cell tumor. Now, there's not exactly a percentage cutoff. People say like 5%, but if you see any like solid nodule with that, nodular like focus, I would call that right high grade. Cool. All right. Here's an
Dr.
idea.
Obadine.
Yeah.
I just noticed the chromatin pattern in the high grade component. Do they usually look like this? It looked like it was like evenly distributed chromatin with a prominent nucleoli.
So sure, again, they will have like small and blue cell phenotype generally. So they're going to be relatively monomorphic cells. There may be
Yeah.
some variation, right? It's not quite like a strikingly monomorphic as like a Ewing, for example.
Yeah.
But yeah, so they're generally kind of like homogeneous chromatin, but this one has slightly more conspicuous nucleoli. But
Okay.
yeah, so they can be kind of like small round blue, just slightly a little bit more open, right? Cool. All right. So yeah, this area sort of incipient high grade in some areas, and then if you start to look around, it really starts to look more and more high grade.
Yeah.
I feel
Okay.
like the vasculature in the high grade component is better than the one in the low grade component arm.
Well, it's not. We always
Squished
hope
together.
the capillaries are nice and clear, but it's not always the case. But here you go. You have these nice, what we call chicken wire vascular spaces. Now, this one kind of looks a little different, maybe because it is low grade, but it's so hyalinized, right? And you can almost not even really make out the vessels in a way. But that's because this is treated. So this is post-radiation. It's very typical for post-radiation therapy. You start to get a diffusely hyalinized stroma, and the vessels almost start kind of hiding, right? But you'll still see a lot of univaculated lipoblasts, and that kind of separates it out from other things. All right. Okay, moving on here. Okay, so myxoid liposarcoma is malignant, right? There's high risk for metastatic spread in these tumors, though growth can be slow for low-grade tumors, right? They can be kind of delayed. You can get weird sort of delayed mets like years down the line, but they still met out pretty high rate. And the weird thing is that they tend to met out to other soft tissue sites. That's kind of a unique thing about myxoid liposarcoma. So we separate them in the low and high grade. Low grade is going to be more myxoid background, low cellularity, right? High grade, you're going to have that high cellularity nodular focus, right? So here's your criterion: myxoid background, arborizing or chicken wire capillary architecture. If you got yourself like a chicken coop back there, you probably have some chicken wire. Basically, just kind of like arborizing vasculature. Primitive spindle to kind of stellate to round cells is what makes up the stromal cells. And then lipoblast, lots of them, mostly univaculated, but you can get multivaculated as well. Nicely, for myxoid liposarcoma, there's pretty distinct fusion. And that is boards relevant, it's life relevant, it's relevant to your everyday situation. I would recommend
All the time,
everybody.
even at the grocery store.
Exactly, And it's FUS or EWSR1. These are the two most common with DDIT3. Okay. You can do NGS or FISH are the two ways that we test for these. I think at some point we'll probably talk about molecular at a later kind of more like kind of give a comprehensive thing on molecular at a later date. I have another slide here. Let's see if I can pull it open. Just kind of showing you another example. Here we go. Here's another example of a myxoid liposarcoma. Lots of small lipoblasts, small like ovoid to stellate cells, arborizing kind of capillary vasculature, right? So typical low-grade myxoid liposarc. All right. Almost done, guys. A couple more weird ones. Let's take a look at this one. Okay. Yep. All right. So kind of a bad tumor, right? Necrosis.
Yeah.
What do we see here?
I see a lot of atypical hyperchromatic cells. It looks like a pleomorphic sarcoma, honestly, or a pleomorphic
Jam-packed.
sarcoma.
Lot of atypical cells. What are these
Ah.
atypical cells?
Besides,
What do we see in here? What is going on here?
Yeah, I think it's a pleomorphic lipoblast or an ugly lipoblast.
Ugly lipoblast. Yes.
Or is it hibernoma?
Could be hibernoma. It's a pleomorphic lipoblast. Exactly. So this is an example of pleomorphic lipoblast, right? So to get that diagnosis, you're finding these you're finding these sort of multivaculated or univaculated cells with a hyperchromatic atypical nucleus. That's what we call a pleomorphic lipoblast, right? So this one is chock full of them. So what's your diagnosis?
Pleomorphic liposarcoma.
And you would be right, exactly. This is a pleomorphic liposarcoma, except it's not. This is in the retroperitoneum, and M2 amplified. So this is actually a D. diff liposarcoma, but I'm using it as a good illustration of what pleomorphic liposarcoma
yeah.
like. So this will look like exactly what you expect for pleomorphic liposarc. This one just so happens to be a D. diff.
I can certainly appreciate the indented nuclei that we weren't seeing in the Hibernoma.
Exactly. The vacuolization kind of indents nicely. So a pleomorphic liposarcoma is a high-grade malignancy. It's got a high risk of metastatic spread. Most often it's in the extremities. So like I said, you kind of want to be pretty hesitant to make this diagnosis in the retroperitoneum. As you saw in this case, that guy has a known history of a liposarc, and there was an area around the tumor with well-diff component as well. But the D. diff had a pleomorphic liposarcoma-like appearance, right? All right, so the histologic criteria to diagnose this, you need a pleomorphic spindle cell sarcoma, right? So these tumors fall into that pleomorphic spindle cell archetype, and then variable numbers of pleomorphic lipoblast. So those are diagnostic. You have to have those, right? There's no consistent genetics for IHC. Don't worry about it. It's very complex genetics. Cool. All righty. Moving on to the next one. Okay.
Let's go. Woo!
This one. Here we go. This one should be a little tough, right? All right, so what's over here?
Myxoid. Lipoblast.
Myxoid, yeah. Lipoblast, yeah. What else do you see here? What
Kind of
about
curved vessels.
maybe some curved vessels? Okay. Maybe somewhat capillary system going on. Okay. All right. What do you think in this area? What does it kind of look like?
I mean, it doesn't look like a myxoid, what's it called?
Myxoid liposarc?
Myxoid liposarcoma, because
What's kind of weird about
something
it?
is odd. The vasculature is odd. The vessels are,
Vessels are a little odd. That's true. They're a
yeah.
little bit bigger in some areas. But what about these cells? Are these typical of myxoid liposarc?
No, we don't have these kind of stellate cells.
Right? Yeah. Why are they so kind of, you have some weird sort of pleomorphic cells in here? It's kind of strange.
Yeah.
What about as we start to move away from this a little bit?
Oh,
What's
Huh?
going on here?
Maybe pleomorphic lipoblast.
Yeah, I think
good.
that's true.
Yeah.
Pleomorphic lipoblast, and it's starting to transition essentially to a pleomorphic spindle cell sarcoma, essentially. If we go all the way out here, right? This looks like a high-grade pleomorphic sarcoma.
Oh, yeah.
So what is happening here? What is this tumor?
And I have two thoughts.
Yeah.
One thought is like a myxoid pleomorphic liposarcoma. But for
Okay.
that one, you want to see a myxoid liposarcoma component, kind of typical of a myxoid liposarcoma, which I don't see here.
Okay.
Another thought is could be a diff liposarcoma.
Could be D-diff, right? Could consider that. This
Yeah.
thing was tested as MDM2 negative.
Mm.
Right, right. So I think, okay, what's that? Sorry.
I agree with Hamid. I think it's a Myxoid pleomorphic sarcoma.
Agreed, right. Yeah. So this is a good differential here, and it really hits on the major two differentials you might consider. And I think you mentioned it doesn't quite look like a great myxoid liposarcoma, and I agree, but it kind of reminiscent of it in this area, right? But there's some features that are kind of weird, like the pleomorphic cells that are starting to swim through here. But it should remind you of myxoid liposarcoma in this area. Okay, but that's true. This is indeed an example of a myxoid pleomorphic liposarcoma. And the histologic criteria here is variable amounts of kind of myxoid liposarcoma-like features, but there's a transition to a pleomorphic spindle cell morphology that generally is going to have higher grade features, pleomorphic lipoblast, high mitotic activity, necrosis. And there's no consistent genetics for this, and it's negative for the myxoid liposarcoma fusion and negative for MDM2 generally, right? So we actually think this is more like maybe more related to pleomorphic liposarcoma than myxoid liposarcoma. So these things are extremely rare. Yeah, go ahead. Oh, you're muted, Ahmed, sorry.
Would you consider like a myxofibrosarcoma?
Myxofibrosarcoma, so what's the big differentiating factor? What do we have here that myxofibrosarcoma should not?
The vessel.
The
Not
lipoblast.
the vessels. The vessels. The vessels, maybe you may have some curvilinear type vessels in myxofibrosarcoma, but it's the lipoblast, right? So we see true lipoblast here. Myxofibrosarcoma, you're mostly going to see either pseudolipoblasts or nothing, right? So mucin-filled kind of spaces mostly. All right, so like I said, it's very rare. It's kind of more of an emerging entity. We don't really talk about it much, and it's highly aggressive. Horrible malignancy, usually deep-seated, often in the mediastinum. And this is one of those liposarcomas that more commonly happens in younger patients. So either children or, young adults to, younger than 30. And there may be an association with Li-for-Many. We don't really have strong data on that. Okay, tough case, honestly, with myxoid pleomorphic liposarc. Just remember that it's still going to have a lot of features of a pleomorphic sarcoma. All right, and then this last one I put in here. It's not typical that we see a whole lot of these. I do have some slides, but I just wanted to kind of go through the criteria here because they can be quite difficult to make a true diagnosis of without a whole lot of additional testing, right? So atypical spindle cell / pleomorphic lipomatous tumors. So atypical spindle cell lipomatous tumor is a benign tumor. Our data is currently limited. We don't have that much info on it yet. It's kind of an emerging entity still. So far, there's not really a risk for dedifferentiation, though there's some exceptional case examples being presented here or there. We're not really sure entirely. Usually these are in the extremities of adults. And the reason why I wanted to kind of start with this is because they have a really wide spectrum of morphology between like two different morphological extremes. So they're kind of weird, right? Some are very spindle cell poor. It's mostly adipocytes with some scattered cytologic atypia. Some are highly cellular spindle cell tumors with some more diffuse kind of mild to moderate cytologic atypia. They're kind of weird tumors overall. But here's the histologic criteria that I kind of stick to generally. So you want a variable proportion of spindle cells and adipocytes, and you need at least focal moderate to marked cytologic atypia. If you don't have moderate to marked cytologic atypia, you're kind of out of luck with this diagnosis, right? Better fit somewhere else probably. And these things are going to have low mitotic activity. They're not going to be like a D-diff, right? You may see some typical or pleomorphic lipoblast scattered about. It's not horribly uncommon. And we put them in this atypical spindle cell lipomatous tumor category. because at least some of them show RB1 loss, so they may be related to spindle cell lipomas, but we don't really know. But the big thing here is you might generally will need to do MDM2 amplification to make sure it's not amplified. So let me show you some examples of that. Let's see, whoops, let me hide this. All right, here's one. Here's an example. So again, you see mature adipose tissue here. And a lot of this is relatively bland looking, not a whole lot of spindle cells, right? Collagenous background, but there are scattered atypical cells, right? Yes.
Yeah.
Yeah, these scattered atypical cells are kind of interesting, and they make you feel like this could be a atypical lipomatous tumor, right? But this was MDM2 negative, all right, not amplified. And as you look around, there's kind of some areas that are a bit more kind of myxoid, a little bit kind of collagenous background, and then this sort of scattered cytologic atypia. At least focally, we have some moderate cytologic atypia in some areas. And as you go around the fat, there may be some small lipoblasts as well. So this fits kind of better in not quite a spindle cell lipoma. It fits better because of the atypia into atypical spindle cell lipomatous tumor. So it's a new category that we're kind of wondering about whether this is really kind of distinct, right? So it's a little bit hard to really kind of get everything about this, but that's kind of what I'm showing you here. Yeah, what's up?
Do you look for ropey collagen in this entity?
Yeah, I was wondering too.
You don't have to find it, right? This one does have some nice ropey collagen, but you don't have to have it, right? Not necessary.
Okay.
All right. Cool. Yeah, so it's kind of a weird one, right? But
Weird.
always when you think about this, you should be thinking about ALT, but kind of keep in mind there could be other things in this differential that you might include. Just kind of keep in mind that there's a little more atypia than you might expect for just a general spindle cell or pleomorphic lipoma.
Yeah, it kind of reminds me of the more hyalinized version of the ALT that we looked at earlier. So I'm wondering if, like, post-treatment, do they ever lose in an ALT or well-diff, do they ever lose the MDM2 amplification? It might be a crazy
Well,
question.
generally they won't treat ALTs or these kinds of tumors. They won't treat them with like radiotherapy or chemotherapy most of the time, unless it's in a weird position. And even if they do treat, MDM2 sticks around. It does
Stays
not go
around,
away.
okay.
It's a genetic change, so you won't lose it. All right. And then I think we are almost done. Okay, so I had a couple of non-neoplastic entities. Sorry, we've gone a few minutes over here. But a few last minute things to talk about here because these are the bane of all of our existence as a resident, and you just want to
My
they're
existence.
going to confuse everybody at one point in your career, so just know them and have these in your head, right? So this first, and I just have pictures, I'm not going to have a bunch of slides, right? So this first thing is something that occurs in basically every single lipomatous tumor to some degree and is always annoying because it obscures what you're trying to look for, and it's fat necrosis, right? So always be aware, fat necrosis you're going to see a lot of. In fact, grossly, it may look like a separate nodule, and it's going to be a lot of fat necrosis. The way you distinguish this is by looking for the infiltrate. It's going to be a lymphohistiocytic infiltrate generally because the fat is leaking out, right? And so macrophages are coming in to scoop up all the fat. And then eventually this will progress to fibrosis and scarring. So that's how you start to get a lot of scarring in a lipoma. Okay, that's one thing. Next is kind of a tumor that some people might mistake for pleomorphic lipomas. There's a particular, this is not uncommon where people will get like a little bit of prolapsed fat around the orbit. So you'll actually see it on the eye. I think Dr. Breyer gets these sometimes, but basically they'll take a little bit of the fat to prolapse out the orbit and they'll remove that. And these lesions, the not neoplastic, but they can have these sort of like Teuton-like giant cells, right? Where you see these kind of in the fibrous tissue here. And they can look like pleomorphic lipoma, but it's not really a tumor. Not a huge distinguishing factor, but it's another thing that may be that you may see. Silicone granulomas, everybody's favorite, obviously. You'll see them everywhere. I have gotten several on the butt. They just happen, so the big thing here is they're going to look like lipoblastic tissue, right? It's going to look like a whole bunch of, it's going to look like maybe this is mature adipocytic tissue and a bunch of lipoblast scattered about. Could this be some sort of adipocytic tumor? The big thing here is that these fat spaces are not really fat spaces. They're silicone, right? They're exogenous material. So whenever you see something like this, check the history, right? Are they sampling an area that has been previously had some sort of procedure, that kind of thing. So, and they often happen around the breast as well, right? Just silicone implants. Okay. All right. And then lastly, you have an interesting little condition called massive localized lymphedema. Which generally happens in patients with morbid obesity, right? So these patients will develop they'll develop like an extensive lymphedema that actually causes this sort of like obstruction, and that obstruction leads to things like calcifications and fibrosis, but also some weird sort of degenerative or reactive type atypia in the stromal cells. So you'll get variably atypical spindle cells and multinucleated cells within here. The lymphedema causes a lot of hyperkeratotic skin overlying as well, and you may get edema and fibrosis. These lesions will usually have a bunch of like irregularly shaped lymphatics as well. But it can look very much like atypical lipomatous tumor. So the biggest thing here is one, you can do an MDM2 if you want, but the history is the most crucial thing, right? So usually these patients have sort of morbid obesity, and then often they've had recent weight loss, and that's kind of exposed this tumor mass essentially that they had, right? So that'll be your best bet. I would still kind of consider thinking about MDM2 to do if you're looking at something like this, but there are other features that can help distinguish things. All right, I think is that the last one? No, I have a final little flow chart that should help you guys about how we kind of synthesizing all this to how we might approach these things. So when you have a tumor that has adipocytic tissue present, you want to really think about, is this just like a mostly mature adipocytic tumor, no lipoblast, anything like that? Versus mostly not mature adipocytic tissue, right? So if you're mostly mature adipocytes, right, and no lipoblasts, you're thinking is in a few spots. Could be a lipoma or some sort of variant of lipoma, spindle cell lipomas or pleomorphic lipomas that are much more adipocytic heavy, right? Or ALT, like a lipoma like ALT, right? And if you're looking at something that's more like less mature adipose tissue, you want to think about, is there a pleomorphic sarcoma component to this, or is there not, right? If there's no pleomorphic sarcoma component, thinking about ALTs that are more sclerosing, a little bit more cellular, myxoid liposarcomas, and of course you'll think about liploblasts there. Lipoblastoma, right, which don't have pleomorphic sarcoma component, atypical spindle cell lipomatous tumor, and that's kind of where you'll be in that concept. And if you have a pleomorphic sarcoma component, you really are thinking, is this D-diff liposarcoma, or could this be like a pleomorphic liposarcoma, or very rarely could this be myxoid pleomorphic liposarcoma, something in that realm. And then again, if you're seeing a tumor that may have a little bit of fat in it, but not a lot, consider other lines of differentiation that may have adipocytic metaplasia, right? So it could just be fat that's in another type of tumor, which does happen, right? And then final note on lipoblast, just kind of as a review for you guys. When we think about lipoblast, well-diff liposarcoma, there's usually none. There's very little lipoblast most of the time. Myxoid liposarcoma, there's usually a lot, mostly univaculated. And pleomorphic liposarc can be variable. They can be quite heavy or just a few here and there. But the classic thing is that they are pleomorphic lipoblasts. So that's kind of your review for that, right? All right, that's the end. I know we went on for a while. Now go study, obviously. But feel free to reach out to me. Obviously, you have my Northwestern email, but I have a personal email that you can use as well in case you can't reach me because I don't check my work email at home. So feel free to reach out if you have any questions.
Thank you so much.
Thank you so
Thank you very
much.
much.
Of course. All right.
Thank you so much.
Well, see you guys later. Thanks for stopping by.
All right, see ya.